14 awards for contribution to professional contribution, including IAP Award for Significant Achievement in Teaching, Indo-Asian Excellence Award for Excellence in Biomechanics, Research and Sports, 41 publications on international journals with ISBN numbered books, grant with 1 patent and 3 in process, organizing secretary for 3 national conferences. So we are proud to have you, sir. Welcome. The second judge for today is Dr. Shamla ma'am. Ma'am is also my UG teacher. So I'm blessed today with my UG and PG teacher both. So ma'am is professor and head at Department of Neurophysiotherapy at CMF College of Physiotherapy, Chinchwad, Pune. Ma'am has extensive 20 years of teaching experience in physiotherapy of UG and PG. Ma'am is a PhD scholar at prestigious St. GS Medical College and KM Hospital, Mumbai. Ma'am has been awarded Nobel Medical Researcher Award for the year 2018. And thank you. Welcome you, ma'am. So now I call upon code number 1. Yes. So the rules are, we have been given 6 minutes for the presentation. There will be 5 minutes. At 5 minutes there will be a warning bell. 6 minutes there will be a final bell, and 2 minutes for question answer. Okay. Thank you.
Good morning, respected judges. The topic of my today's presentation is impact of functional task exercises on hand grip and functions in tennis elbow patients. It's an experimental study. As we all know, lateral epicondylitis, very common musculoskeletal disorders. It has pain, tenderness, reduction in the functional capacity of the patient. It affects its activities of daily living. So whatever conservative treatments we are giving right now, usually they are very beneficial, but there are very less concentration on the everyday task, everyday activities which they do. So need of my study, very limited focus on daily functional activities of the patients in rehabilitation of tennis elbow. So there is a very limited research regarding this. That is why the need of my study. This is the hypothesis. Null hypothesis: no effect of functional task exercises on hand grip and function in tennis elbow. And H1 will be, there will be an effect of functional task exercises in hand grip and function. These are some of my reviews of literature. We had done an interventional study, experimental, for 6 months in 50 patients in orthopedic clinics in and around Pune. Patients who are already diagnosed with tennis elbow were included in the study by simple random sampling. So the patients included were both males and females of age group 18 to 35 who were diagnosed with tennis elbow for more than 6 weeks, and we had considered having tennis elbow on the dominant hand and excluded with bilateral involvement, cervical radiculopathy, humerus fractures and any other elbow pathologies. These are the outcome measures. First one was patient rated tennis elbow evaluation scale and sphygmanometer test. So we had taken permission from institutional ethical committee and approached different centers and OPDs, and their permission was taken. Consent from patients were taken. Explanation of the study was given to the patients, and who were willing to include in our study were included. Then pilot study was conducted and errors were resolved. Pre-treatment assessments were done. We have given 45 minutes of sessions for 3 times in a week for 4 weeks, and we had done post-assessment for 2nd week and 4th week. So these are some of the exercises which are included in your functional activities or functional retraining. These are the results of sphygmanometer test. Pre-treatment on grip test of sphygmanometer was 54.67 mean, and it has increased. So grip strength was increased in functional task exercises group. This is the sphygmanometer test for control group, that is group B. So here also the grip was increased. the from mean plus and minus standard deviation. This is the table which is representing the hand function using PRTT score, that is patient rated scale. In this, the hand functions, pain was reduced, hand functions were improved. So totally their functional independence was improved. So why this result actually? So task oriented training, when we give, we concentrate on both the clinical recovery as well as the daily living of the patient. So mostly the patients are concerned with their activities of the daily living. So this task oriented, when we specifically go on repetition of the activities, activation of the muscles, will be more helpful. So the performance of the functional task exercises include teamwork of cognitive as well as perceptual as well as motor function. That is why the functional task group gave us the better result than the conservative treatment. So coming to the conclusion of the results, there was significant improvement in the hand function and the grip strength with functional task exercises when we had compared it with the control group. So coming to the limitations of the study, genders were not separated. There was no comorbid factors included in the study, and we had not selected the particular any profession for that. So for the future scope, we can go for the correlational study between the pain and physical functions. We can consider particular professions, and we can do the comparison between both the genders to see whether any particular gender has more effect of that functional task exercises or no. These are some of the references. Thank you.
The paper is open to the house for discussion. Any questions from the audience? Any questions? Any questions from the judges, please?
What was the maximum duration of tennis elbows diagnosis?
More than minimum 6 weeks,
Yeah,
and
maximum?
what we got were total till 1 year.
Okay, not more than that.
No, not more than that.
Yeah, congrats for your work on tennis elbow.
Thank you, sir.
Because it's not quite a common condition where you get some better results.
Yes, sir.
I just would like to go back to your data.
Data analyst.
Yeah. All right. So you can just tell me what statistical method did you use for your analysis?
Sir, yes, sir. We had used SPSS software. In that, we had taken between the groups paired t-test, and between the two groups, we had taken unpaired t-test, and we had taken into consideration mean plus and minus standard deviation.
Right. So did you check for your data homogeneity for this?
Uh,
Since you have taken a PAT test.
yes, we had checked.
So how did you check it?
Yes, before taking that into consideration, once we
Because
had taken, but
distribution of normality, if it have been there, if you just look into this group A, which shows me 54.67,
yes, sir.
and the next slide it shows me 53.7.
Yes,
so
sir.
it looks, the pre looks in both the situations, it looks the same, and the difference looks to be around 7 points over here, and
Correct.
probably around 8 points over there.
Yes,
But
sir.
look into the next one. It is your pre-score of group A and group B is 59 and 49. The difference of the scores of PRTT is 10.
Yes, yes.
Now this indicates that there is no homogeneity of the samples, or probably there is no normality distribution of the samples.
Sir, can I?
Yeah, please.
In this scale, one major concern was regarding PRTT was it is mainly subjective scale. So whatever the patients told us, we had to consider that only. So maybe from that perspective, bit homogeneity was not.
When you are taking a subjective scale, how could you get into a PAT test? Since it is a non-parametric data.
But sir, your scoring is objective only
This
out of
particular,
100.
but your data is subjective, which is non-parametric in nature, because you don't do an evaluation and get a data out of it. It is what I perceive and assume and tell you about it. So there is less, because subjective data usually have less reliability into it.
Correct.
And even there is a less reliability of the subjective data, it is essential that you go for distribution of normalities. distribution of normality is not being done, then it is quite difficult to go in for a PAT TT. That's what I assume.
Okay.
Experts can probably tell.
Sir, what was our actually thought process while doing this? This scale, usually we take the matter or whatever the parameters from the patient, but scoring is done objectively only out of 100. That is 21 out of 50 is mild, then 50 to 100. So what I thought, when we are getting that score objectively, so we can use.
Yes,
but I'll
yes.
surely
Objective
check.
score is fine. What sir wants to say is, you have to do a normality check before you want to go for a
Surely.
parametric test.
Surely
That
will.
is the takeaway from the paper.
We'll surely work on it, sir.
That's good.
Thank you.
Thank you so much.
Thank you.
Now I request Kinesiocon F02. Thank you.
Good morning, one and all. My topic for today is health status of chemical industry worker and alarming reality. So yesterday we were all having a power pack sessions of ergonomics, and there we understand there is a need to understand the health status along with, so work should get fitted into workers. That's what we've been studied since our final years. So here we are showing a data that we have analyzed for a chemical industry worker. Now chemical industry, so chemical industry, right now we are seeing a rise in pharma industries, or there are certain other chemical industry which supports these industries. Here there is more risk of respiratory conditions concerning because there are a lot of chemicals in which they interact with. Likewise, we have gone here, we have taken the chemical industry, which is a high risk workspace, which in which the employees were exposed to various hazardous substances such as methane, whose permissible limit is 100 ppm. But what we had observed, as it was an observational study, we had gone to this workplace and observed that this 100 ppm was far more, like it was far more exceeding this limit. Also acetone, whose permitting limit is 1000 ppm. So there are studies which say this would have a ill effect on the health. So workers are particularly prone, as I discussed, prone to respiratory problems, skin disorders. Fatigue is one of the common reason there, and carcinogenic risks are also there. There is also studies which shows that there is a relation between the one's body composition to the respiratory conditions. So there is a need for study is, so because of the prolonged exposure to the hazardous substance, knowingly or unknowingly, the worker is undergoing a lot of health sufferings, which they are not able to understand, or they do not would like to cope up, considering it is their bread and butter. So this study would like to enlighten them to make understand people ki this is having some problem. In spite of using PPE kit, there might be some underlying causes which would create issues with the health concerns. So aim is to assess health, fitness and respiratory functions in the workers in the chemical industry. It was a biphasic study. Right now I'm presenting your first phase, that is the observation study, and further we have analyzed it. So objective was to evaluate the general health and fitness level using a bioelectrical impedance, then to assess the respiratory functioning using the auscultation and the peak flow respiratory rate, and to analyze the impact of both in the long-term exposure of the workers in the overall health. So it's an observational study. Chemical industry workers were there. It was a convenient sampling with the sample size of 28, and it was a chemical industry setup. So they were, both the genders were included here. They are working for a whole shift. It is a it's a shift of 8 hours, and it's a rotatory shift. So they have 3 phases of shift, 5 days a week, and those who will be willing to participate, we have included them. Exclusion criteria: those who are having already some pre-existing conditions, cardiorespiratory conditions, and those who are on medications for any systemic illness or any other complications, if any. So here we got the mean age is 35.75 plus minus 11.6 years. Now here we had seen a vast variety of people, right, from the young age till the 60 years of age as well. Mean work experience was 9.3 years, and average working hours was 10.2 hours per day with 1 hour of rest break. So mean vital parameters, as you can see there are vital parameters such as pulse rate, respiratory rate and blood pressure, which are somewhere lying on borderline. They are like pulse rate of 94 beat per minute, respiratory rate of 23 breaths per minute, and blood pressure is 132 by 84 mm of Hg. Respiratory function, so mean PA for what we have checked was 290.71 liter per minute, which is lower than the ideal values. It is again borderline, it is not much lower, but definitely there is a significance. Now our concern is about even the health and fitness levels. So they were having a mean BMI of 26.44 kg per meter square, which is an overweight range. Then there is a skeletal mass of 29.35%, body fat is 27.74 and visceral fat is 11.8. Here body fat and visceral fat is where I would like to put your attention, because this is important. Visceral fat is somewhere between 4 to 5%, and as we know it is going to lead to risk of your cardiovascular diseases. Even the visceral fat, even the abdominal fat, we know all the ill effects for the same. So the additionally there was a reduced PFR suggesting the respiratory functions, and so we are concerned about the occupational hazards which are faced by these chemical workers. As we have visited it, we know that there was PPE kits, but still these factors are still there. It was mechanical, not completely manual work, but still we are seeing this readings that, I mean, this outcome measures are showing us this. That means definitely there is some problem, the way of working or the environment per se. Hence the conclusion.
Thank you for your presentation. The paper is open to the House for the discussion. Any questions from the audience? Anyone? Any questions? Judges, your question, please.
Appreciate the efforts of identifying a health risk of people. The study could have been more impactful if you would have gone more deeper into the concern, because when you're saying that those people had anything between 100 to 1000 particles per million as an exposure rate, so there is nothing that is causing them a trouble for the respiratory component. That's what you mean to say?
There was more than that.
It was more than that. So what about your evaluation on the cardiovascular and respiratory areas? Because your study was more focusing on your
Health parameters.
the parameters of fitness, but not on probably your cardiorespiratory areas. Could have been dealt more seriously into that, because like when I have a problem of a particle that is more in number that gets into your lungs or get into your other systemic disorders, I think the focus should have been on that area than this. That's what I assume.
Sure. Okay.
Okay, maybe you could have done it, or you have done it, you have not put it over
So
here.
second phase was there, but till we submit it was not done, so I could not show.
Okay, fine. Because that's what listen, for every study there is something called a primary objective, the primary
Yes,
focus area. The primary focus area could have been that than this.
Sure.
Thank you.
Thank you.
A good study. What I feel is, I agree with sir that you could have gone into little bit more details of respiratory evaluation. Probably you could have used PFT or similar sort of a thing. I just have one question. Why your sample size was just 28? What was the number of workers there?
So ma'am, total number of worker was 32. We tried
Okay,
to
only
take
32 were there.
Yeah.
Okay, and willingness from that
Yes,
you got
yes. Even
28.
absenteeism and all considered.
Okay,
So we
fine,
tried
fine.
to take the 100% samples as possible.
Okay, fine. Thank you.
Thank you so much. Now I call upon KCON F03.
Okay. Good morning, one and all. My topic for today is ergonomic evaluation and intervention for neck, back pain, and disability in fashion designing students. It was a two-part study, quasi-experimental study with a pre and post-intervention design. So, fashion designing students undergo a lot of jobs, that is sketching, cutting, drafting, and repetitive and skilled manipulation of the fabric. And back, neck, wrist, and shoulder pain are very common in them. So the need for the study was repetition, force, static posture maintenance, and vibrations are associated with all that which causes the work-related musculoskeletal disorders, and all these factors are involved in the fashion industry workstations. So it was our aim to evaluate the ergonomic factors and correct them wherever required, and in order to prevent the work-related musculoskeletal disorders in people working with fashion industry. So the first part objective was to evaluate the ergonomic factors which are associated with working in Fashion Designing Institute. We only concentrated here the bodily ergonomics, as well as we have taken some furniture measurements here. And the second part was to assess the effectiveness of cell-designed workstation exercises and give them the ergonomic checks for the back and neck pain and disability. So study design was a two-part quasi-experimental study with a pre-post intervention design. Sample size was 30. It was a convenience sampling, and students studying in the Vocational Fashion Institute were our samples. Age group was 18 to 24 and experience more than 6 months. So the ethical clearance from the institutional committee was taken, permission from the institute and written consent from the participant was taken. Then we had made the self-design questionnaire, in which we had asked them how many hours do they work, in which position do they work, how was the position when they start working, and at the end of the work, what was the position of the elbow. So all sorts of questions were asked. Video analysis of the workstation posture was done, and workstation furniture measurements were taken. In the second part, we have given them self-designed workstation exercises and ergonomic corrections for neck and back and disability. Outcome measures were assessed, baseline and 3 weeks post-intervention. Physical follow-up was taken every alternate day for 3 weeks. And after 3 weeks, we have assessed them again. So these were the workstations: sketching, cutting, drafting, and stitching. They used to do 2 times a week, and the work duration for all 1.5 to 2 hours. And these were their pictures when they were actually performing their work. The first 2 pictures shows the sketching when they were doing sketching. The next 2 are the drafting, and the third one is the stitching. So you can see here that they are maintaining the flexed posture, the elbows are away from the body, the neck is in the flexed attitude, and they were not doing any variation in the jobs, and they were not taking any rest periods in between. So working hours were 5 or 6 days a week, and all activities used to carried out one after the other without no break. So descriptive factors about them: position of working mainly standing or sitting, division of work was not done, change in position was not done. When we assessed, most of them had pain when we were evaluating or when we were asking them questions, and areas of pain mostly were back and neck. And all of them could relate their pain to the working posture. And the measurements that we could take of the furniture, that is the drafting table, ironing table, stool, chair with armrest, all were matching with, most of them were matching with the ergonomic guidelines. Then we had done the post-intervention, pre-post 3 weeks we have done. So we can, here the table shows ODI, NDI and NRS values. And if you can see that there is a lot of difference between the pre and post values, with the p-value 0.001. So we have done the Wilcoxon matched pair test to get the results. And what we have found out is students were unable to attain and sustain the optimal posture. Students do not pay attention to the posture when they get engrossed in the activity, and that is why the main reason that after giving ergonomic corrections also they don't pay attention to the ergonomic corrections. So giving them the workstation exercises causes the active break, which can be used as one of the variation which they were not doing. So giving them some other task to do, other than that they can stop in between the activity after 1 or 2 hours and do this variation of 5 minutes and get back to the work. So, and it has been proven that exercises and ergonomic corrections decrease the exposure to the work-related musculoskeletal disorders. And if the sufficient rest is given in between, which we are calling it as an active rest because it is proven beneficial than the passive rest, leads to decrease in the tissue inflammation and the micro damage. So, combination of the workstation exercises with ergonomic interventions is more beneficial. So, one of the study that we came across when we were looking for the literature, that the regular exercises at the workstation were really helpful in a short term, and if we include that regularly after every 1 or 2 hours, the reduction in the musculoskeletal discomfort will be more lasting. So active exercises and active breaks are more beneficial. So mechanism can be targeted muscle activation, neuromuscular re-education and psychological modulation to get the effective benefits from the workstation exercises along with ergonomic guidelines. So our conclusion was the ergonomic factors, especially the bodily factors, were not optimal in students working in Fashion Designing Institute, so making them susceptible for the work-related musculoskeletal disorders, and workstation exercises with ergonomic corrections are effective for back, neck pain and disability in students. The limitation of our study that we could not include any control group because we did it in the fashion industry firm, and pre and post we have checked the corrections. Thank you very much. These are my references.
Thank you so much for completing on the stipulated time. Any questions from the audiences? Any questions? Judges, your questions, please.
Nice work.
Thank you, sir.
Few clarifications needed.
Yeah.
Yes. Your conclusion claims, the next slide,
Yeah.
economic factors are not optimal in students working in Fashion Designing Institute,
Yeah.
susceptible to work-related muscular disorders.
Correct.
That's fine. Just one of the previous slides,
Yeah.
where you had a table given with yellow numbers given.
Yeah.
Here you mentioned that most of the previous one, I suppose, that most of the height measurements were matching with the ergonomical needs and the design criteria. Right. So in the previous slide you mentioned that all your height variations and inches are meeting your design criteria of ergonomics. And the last conclusion you said like it is not optimal. So
Yeah, so the bodily positions were not optimal. So if we see, we could only find out, I did not mention it here, but we can see that only the drafting and cutting table, the ideal height is, it is within the range, but it can vary between 25 to 32 inches according to the person's height. So it was lying in that range, so that is why I said that it is within that limit. But when we were talking about, when we were measuring their or analyzing their videos and checking how they are maintaining the posture, so that time we could find out that if we can just give them the postural corrections, of course the furniture is most of the part we have to correct it, but if we make them feel that only doing by these workstation exercises you can get the improvement, and maintaining their proper posture if we can get it, so maybe they can just give add-ons to their furniture instead of changing the furniture. So that was the thing that we wanted to tell them, that it is very, very necessary to keep up with the variations in the job as well as take breaks every now and then. So that was our main focus, to make them realize that the bodily interventions are effective.
Right. Now,
Okay.
the work done from you is really appreciable.
Thank you, sir.
And on the other side, like this is something that it is a mandate stuff as a physical therapy that you should be knowing about it when you're doing it.
Yes.
Maybe it is not known to those people.
Yes.
So what were the difficulties you faced when you try to explain them that what is to be done, what is not to be done?
The difficulties what I faced, first there was not awareness regarding this. So when I started talking to, these are the students, very young age students. So first to gain their attention, what we were talking. So they were first not ready to believe that these many micro correctional exercises will be beneficial to them. But then first it was not decided that every alternate day we will visit the firm. But then after looking at their response, we started visiting the firm, telling them that we have to do this. And when they started doing this, after a week or so, when they started seeing the results, then it was not a problem for us to make them get into the routine. But first 1 week was a task for us.
What's your long-term goal based on your study?
The long-term goal will be, we have to check, take a control group and check whether this can be used for a long term, maybe after 6 months, 1 year, and to do the effect of it.
Nice efforts. I just want
Thank
to
you.
ask you whether a follow-up of this particular study is in consideration.
Yes, ma'am.
How
Yes.
long? After how
Ma'am,
many?
we are taking it for 6 months now because,
Okay, because
most of
these
the
are all premature.
correct,
right?
So they when they'll start working, we'll have to
Yeah.
see. Correct. Yes. So we
Okay,
are
things
working
would
on
change
it.
after that.
Yes,
Okay.
sure.
Yes.
I know.
Thank you.
Yes. Thank you. Thank you.
Thank you
very
so much.
Yeah.
Thank you, everyone. Now I call upon Kinesiocon F04.
Good morning, everyone. My study is ICF-based study on association of sleep quality and lifestyle on depression, anxiety, and stress in homemakers and professional women. Coming to the introduction and need for study. So we all know that women experience unique sleep challenges due to hormonal changes like pregnancy, menstrual cycles, and perimenopausal period. Also, we need 7 to 9 hours of restful sleep every day. If this is not met, you generally end up having emotional instability or mood disorders. Insomnia is more common in women, yet its lifestyle links remain unexplored. So this study was important. Homemakers and working women face different lifestyle demands affecting well-being. Like homemakers have different challenges. They are more involved in the domestic chores, caregiving, whereas professional women are involved in social support, financial stability, and job equality. So ICF was taken for this based on analysis provides a holistic framework to study health and functioning. So ICF was involved. The study focuses on understanding how sleep quality and lifestyle impact stress, anxiety, and depression in homemakers and working women. It was also important as to provide insights that can help improve targeted mental health intervention, which is like mainly neglected. We only focus on the physical health. Mental health is ignored. So this was important. Coming to the aim of the study was to determine the association of quality of sleep and lifestyle on depression, anxiety, and stress in homemakers and professional women using the ICF. Therefore, the objectives were, primary objective was to evaluate sleep quality among homemakers and professional women using sleep quality scale. Secondary objective was to determine anxiety, depression, and stress if they are influenced by sleep quality and lifestyle using the DAS-21 health profile 2 and the ICF. Methodology. Source of data was like this study was done in Karnataka in the urban communities. Study design was observational and a cross-sectional type. Homemakers and professional women in the age group 19 to 45 were included in the study. And the data collection was for 6 months. Probability sampling was the sampling design. Systematic random sampling was done and data was collected in one time. 310 women were included in each group. The total was 620 women. Now coming to the inclusion and the exclusion criteria. Females in the age group 19 to 45 years of age were included. Professional women having work experience of at least 1 year and working hours should be at least 6 to 8 hours. These women were included for the inclusion criteria, and exclusion individuals with existing medical or psychological conditions, also diagnosed cases of depression, psychosomatic disorders, anxiety, systematic disease, pregnancy, or recent injury or stress, like in the family if there was any death or any stress causing factor, then those were excluded. Also night shift workers were excluded because they have different sleep patterns. Outcome measures that were used were the sleep quality scale and the health promoting lifestyle profile 2, DAS-21 was used, and the ICF profile, the profile was created using the 10 codes. Coming to results, the results on the left hand side, if you see, comparison of professional and homemakers, professional women and homemakers with the levels of depression, anxiety and stress was seen. This is a bar chart representing, like if you see under depression, the first one is normal. The second column where it is mild to moderate, and the third section is moderate to severe. So depression was seen more in homemakers as compared to the professional women, whereas anxiety was more or less the same in both. Stress was seen more in professional women as compared to the homemakers. Coming to the coming to the diagram which is there on the right hand side, comparison of both with the levels of sleep quality scale was done. So if you see like 11 to 20, the lesser score bracket, professional women were involved in lesser scores, whereas with the higher number, the homemakers were included, which shows that homemakers had worst sleep quality as compared to the professionals. Also, Carl Pearson's correlation was done, where depression, anxiety, stress scores were correlated individually with SQS, the lifestyle profile, and the lifestyle profile. Two showed significant results. The spiritual growth and the stress management was better in the homemakers as compared to the working women. So overall, it suggests that in homemakers, sleep quality was worst, but their coping mechanism was better, as they had better spiritual growth as well as better stress management. Whereas in working women, their sleep quality was better, and their sleep quality was better. Discussion, comparison of depression, anxiety and stress in both the groups was done. So depression was mild to moderate in homemakers, that is 42%, versus with working women it was 17.75. Stress was moderate to severe in working women, which was higher. Sleep quality comparison and correlation, findings are consistent with the previous study which was done, and we also found out that sleep quality declined with increasing age, and most significant were the two codes of the ICF, maintenance of sleep and making decision. This suggests that sleep quality not only affects the physical capability but also cognitively it affects a woman. Coming to the conclusion, the study found that that most women, whether homemakers or professionals, experience significant sleep disturbances. Sleep quality was closely associated with levels of depression, anxiety and stress, highlighting the influence of lifestyle factors. Additionally, the ICF function profile proved useful in evaluating sleep quality. Thank you.
Thank you so much. The paper is open for discussion. Yes, sir. Please.
Yes, sir.
No, it's not. It's a very nice paper. But the main problem is, the economic condition of the
Yes, sir. Yes, sir.
and the profession.
Yes.
So, in which way you can correlate, or which way you can compare these two things in the background of economic conditions?
Economic
They are
conditions.
totally
Dependent.
and they are not dependent.
Yes.
So, in which way you can compare? The
Okay.
comparison will become difficult to compare, mainly in case of the depression.
Yes.
You found the depression.
Depression.
Less in case of the profession.
Yes.
Than in the home. So it's a very interesting finding. And the second thing is the stress. Stress level is more in case of the homemaker. You found that thing.
Stress was more in working women, sir.
Right. Stress level is more
In working women.
because due to the office work. And
Yes,
other
sir.
things
Job
are there.
demands, yes.
So maybe stress somehow it is related to the economic condition, but more or less the job stress.
Yes, sir.
Very much.
Balancing, juggling with both
And
the.
And the second, so you have to do, this may suggestion. You have to do psychosocial questionnaire. There is a very good questionnaire, psychosocial questionnaire.
Okay.
If you perform that questionnaire among these two groups, then there's economic conditions. You will find out the economic stability and the conditions between the two. It will vary, but easily you can identify.
Okay. Yes, sir.
And the second thing is that is the sleep is very much related with the chronobalance. Do you have any idea about the chronobalance? Sleep wakefulness. Because some people are very active at night, some people are very active at day.
Day.
So this is a morning type and evening type, morning type and evening type. So So that thing is come here.
Okay.
So you please perform that questionnaire. There's another questionnaire there, already
Psychosocial.
formatted questionnaire, so that you can find out it is these two type of people are there or not among this,
Okay.
among your part.
Okay, sir.
Very good.
Yes, sir.
Okay.
Thank you.
Thank you so much, sir, for your time and suggestions. Judges, your questions, please.
Good attempt. Can you go to your inclusion criteria?
Yes, sir.
So I personally feel you have taken a very wide age group from 19 to 45
45.
years, because individuals have lot of different goals in their lives. Their
Yes,
responsibilities
yes,
are
ma'am.
different. Even if you consider professional women, their responsibilities at work,
Are
the work
different.
culture, everything differs. And sir has already given you a lot of suggestions you can work out. Also, 1 year of experience might not be too considerate for this type of a study. Probably they are still into learning phase. Most of the places
Yes,
they have
ma'am, but
6
then-
months of probational period itself, right?
Okay.
So they should be engaged into professional activity fully. Then only you can compare difference between professional and this thing, because there are a lot of people who drop their job and go back to the homemaking
Homemaking
business,
business.
right?
Yes, ma'am. I'll take that into consideration.
Appreciation goes for your work,
Thank you,
as
sir.
usual. Just in line with Sir's suggestions, definitely economical situation has to be considered. And as ma'am said, your psychosocial life component as per age. Probably what you can do, probably the next component is you can bracket them into different cohorts, or probably you can segregate them as per age categories,
Okay.
or either number of years after marriage or number of years of the work experiences, and equate them on the age groups or equate them on certain criteria
Okay.
between maybe less than 25 to 35 and 35 to 45 or somewhere. How do working women and probably your homemakers, how do they differ, how do they vary, and where somebody, because it might happen that at the very younger age, people, homemakers are probably better enough. As they keep growing up old, the stress and anxiety might become more. Probably as an office individual, as they grow more in office categories, their stress level might come down, or might go increase depending upon the work status and the culture. So you can think about having a subgroup evaluations into cohorts and doing it up next. And third thing is, like, one thing which you forgot, probably looked in, is the family quality.
Okay.
The family quality, a number of family members it makes a big difference on your stress, anxiety,
Yes.
and the sharing component
Yes,
of it.
sir.
And there is a different category in your family these days. There is something called as a working woman who are not a homemaker. This is actually developing up now. You have a homemaker, you have a professional. Now you have a professional but not a homemaker.
Homemaker.
I am working and I am just working. Like, this is a conversion of a masculine, what you call dominancy, is coming into feminine dominancy in this generations now. So I am working, that's what the females do these days, and why should I work it at home? So this actually happens, and this probably can be considered as a futuristic component to find what happens to those people later. Alright, so this is a good attempt at a different thought process, appreciation for that.
Yes, sir.
But these things could have been considered for a better more context of an outcome of a study.
Okay, sir.
Thank you.
Yes, thank you.
Thank you so much. Audience can give a round of applause for all the papers. Thank you. Now call upon Kinesiocon F05.
Good morning, everyone. Everybody's very favorite topic nowadays is or has been mechanical low back pain. Especially after COVID, the cases of mechanical low back pain or work-related musculoskeletal disorders have increased exponentially. Hence, we tried to compare the effect of yogasana and work ergonomics on pain and disability in information technology professionals, which is one of the most hit section by mechanical low back pain post-COVID. So low back pain, globally, the prevalence of low back pain is 84%, and it is one of the major causes of disability. Mechanical low back pain is one of the most common types, cyclic, posture-related, and linked to occupational traits. It causes around 6% of Indian computer professionals have reported musculoskeletal disorders. Amongst them, 51% are prevalent for the low back pain. Risk factors for the mechanical low back pain in IT professionals mainly being poor posture, static sitting, flexed lumbar spine, psychological and occupational stressors. The conventional management has always been targeted into activity-related advices, self-care, medication and physiotherapy in the form of stretching and strengthening of the particular muscles according to your assessment. We targeted yogasan because it is a combination of stretching and strengthening exercises. Along with that, it also concentrates on breathing, which is one of the technique in the medication which helps to eliminate your psychological stresses. Along with that, ergonomics is a workstation designing, postural training, which also includes rest breaks and exercises or cyclic exercises, which is also known as your active rest, which is seen to have reduced low back pain or any musculoskeletal disorders. So the aim of our study was to compare the effectiveness of yogasan and workplace ergonomics on pain and disability in the IT professional workers with mechanical low back pain. The outcome measures that we used were visual analog scale and Roland-Morris disability questionnaire. So we assessed these two outcomes pre and post in our group 1, which was yogasan group, in group 2, which was workplace ergonomics, and then we tried to compare the same in between the groups. The study design was experimental study. It was a comparative study. Sampling was convenient. We had 36 participants in each group. The group 1 was yogasan and group 2 was work ergonomics. The inclusion criteria was IT professionals working for more than 3 years in their profession. The working hours should be at least 9 hours or more per day, 5 days a week. And with mechanical low back pain, whereas exclusion criteria were any recent surgeries or any diagnosed conditions of PIVD along with neurological symptoms were excluded from the study. Then group 1 was given yogasan. There were 5 yogasans which are given in the table. They were given. The repetition was at least thrice, and the whole time for first 2 weeks we started with slow. We started with 10 to 20 seconds with 3 repetitions, eventually increasing into 40 seconds and repetitions increasing to 5 repetitions. There were 30 sessions conducted throughout the 6 weeks. Out of that, 10 sessions were observed with online platforms like Zoom. Whereas for the work ergonomics groups, participants were assessed using workstation ergonomics self-assessment checklist. Then a brochure was given and they were oriented to the idea of ergonomics. With that, they were given one-time education session for correct posture and importance of breaks in between. Some workstation stretching exercises were given which were used as a active rest period. Repeated repeated reminders were given online for the breaks, as well as reminders for sticking to the ergonomic setup were given to the participants. Coming to the results, the baseline comparison shows that both the groups were comparable baseline with respect to age, years of experience and working hours. Hence, both the groups were comparable at baseline. Baseline comparison of VAS and RMDQ was also assessed, which suggests that both the groups were comparable at baseline. Within the group comparison shows that both the groups improved, where there was a statistical as well as clinical significance. When compared between the groups, there was a significant improvement in yogasan group as compared to work ergonomics groups. With the conclusion we come that both yogasan and work ergonomics were effective in reducing pain and disability among IT professionals, but only pain was statistically reduced in yogasan group as compared to both the groups. Even though there was a reduction in both the groups, and yogasan was better. The ergonomics groups cannot be denied because they were, even though it was improvement, that was just a statistical improvement. Clinical significant improvement was not much achieved. Hence, we can also say that yogasan and work ergonomics were comparable in context of reducing the disability in those particular patients. The limitation of my study was the group size was small. Along with that, the adherence to the workstation ergonomics was not assessed. These are my references. Thank you.
Thank you so much. The paper is open for the discussion.
It's a very nice paper.
Thanks.
You know, I should say, number one, it's a nice paper, nicely done. Of course, the number of subject group is less, as you already mentioned. But I have some reservation on the term work ergonomics.
Yes, sir.
Actually, ergonomics, if you just break the ergonomics, that term is actually there are the two Greek words. Ergo means ergon, means work,
Yes, sir.
and nomos means the laws. So you are mentioning work ergonomics means work, law.
Okay.
So that must be workplace ergonomics.
Yes, sir.
That should be workplace ergonomics.
Yes, sir.
And the second thing, I couldn't find that the very popular questionnaire to identify the musculoskeletal disorder that we are using, decades for decades. There's a Nordic musculoskeletal disorder questionnaire.
Yes, sir.
So-
In this, we targeted the low back pain, mechanical low back pain. That is why the Nordics questionnaire was not included in the study.
But you can include that thing, Nordic
sir.
musculoskeletal disorder. Maybe you have to modify this thing.
Yes, sir.
And then again you have to find out the reliability of the questionnaire before, using that questionnaire in your case. But it's a very nice question. Very, very nice work. Thank you.
Thank you, sir, for your suggestions. Any more questions from the audience, please? Judges, your questions, please.
Us appreciating your work, few concerns. Could you just get back to your analysis?
Yes, sir.
Now, usually in a Roland's output, we say the percentage difference is to be considered. Probably I could not find the percentage differences of your pre and post. Was it purposely omitted?
No, sir. So basically, with the norms that we were supposed to keep it within the limited period, limited slides, we have just put the conclusion. We haven't put the details of the statistics.
Yeah, but if you have to tell me that there is a change or there is no change, you're going to compare between section A and section B. It is Roland questionnaire usually uses your percentage score.
Yes, sir.
And the different
Definitely.
scores,
Yes, sir.
and that is the output of your data that is to be expressed.
So between the group, when we compared for the group 1 and group 2, that time we found out that group A was statistically better. That is what the effect sizes we given, sir.
So statistically better, it means that
But
like
it was not clinically better.
Because like it is just a mathematical component of everybody shows you less than 0.1, each one is statistically better.
Yes, sir.
But when it comes down to, because it is very clearly said, like any difference of 20% is only considered as a change, and if it is more than 60% is what is expected to be, is what is a major change.
It's a clinical significance.
That's
yes,
what
sir.
is not, that's probably is missed in over here, number one. And number two, like I just wanted to know, now low back pain is a global problem, and for centuries and centuries, okay, thousands and lakhs of research are working on it, and till now there is no permanent solutions.
Absolutely.
Nobody have never got it, nobody is going to get it also in the future, the fact of it. Now, the one basic concept is that it has to be a holistic, globalized component of management.
Yes, sir.
Psychosocial model, that's what is being recently being taken up. Alright, so biosocial-psycho model. Now, when it is the updated upcoming component, now why have we gone down to the same basics of dividing a mechanical context against economical or probably a law content? Because now they are coming down to this biosocial-psychological model.
Yes, sir.
Combine everything and put it. Make a khichdi and give it to the fellow comes out of it. Now you have gone back to the same old tradition of finding out what can happen with the mechanical context of stretching or working on your muscles, or realigning a component, or trying to go ahead with your workplace models of your loss. Now, is there any reason why you want to go back to the old schools when the new schools are come today?
Sir, in Yogasan, along with the exercises, it also takes care of your psychological component. That is why we thought that this could be used for the study. Sir.
I don't think this yoga that probably are given takes care of a psychological component. I just don't believe.
Okay, sir.
Fine, it's my personal opinion, because like going with the trend, we'll have to go ahead with this. You have to go ahead with your biosocial-psychological model, than breaking out, unless you have a specific objective that what this particular structure is going to give me something specifically into it, then you can go for breaking out to the back to your old school of thoughts. Otherwise, it's better you go with your new trend. That's what I assume. That I prefer.
Yes.
Thank you.
Considering the time limit, I would just appreciate your study, and just a word of caution when you use the word yogasanas, because yoga itself is a big concept.
Yes, sir.
And
Yes,
yogasana is the third step of the Ashtanga yoga. And you have considered just few asanas.
Yes, 5
So
asanas.
instead of calling them yogasana, personally I feel we should name them as per our own exercises, because from your presentation, I felt you have not considered the whole concept of yogasanas, or probably you might have missed out.
Ma'am, I couldn't explain this in this limited period of time, but yes, we have concentrated on the other components of breathing as well as the relaxation, which we do as a pre-part of asanas, and then the
Right.
this thing also, ma'am.
Okay,
Yeah.
thank you.
Yes. Thank you.
Thank you so much. Now I call upon Kinesiocon F06.
Good morning, judges. Good morning. Going with the theme of Kinesiocon 2025, Prevent, Protect and Perform, wish to present a study titled Effect of Brugger's Postural Relief Exercise along with Craniocervical Flexion Exercise on Craniocervical Alignment and Deep Neck Flexor endurance in patients with forward head posture. The forward head posture in individuals aged between 18 to 25 years, the prevalence is found to be 52.9%. It's associated with weakness in deep cervical flexors and shortening of cervical extensors. It has been found that 73% prevalence of forward head posture affects the activity of daily living to some extent. This forward head posture not only changes the alignment of the neck but also changes the position of the scapula and reduces the endurance in the deep neck flexors. Conventional deep neck flexor endurance exercises lack recruitment in functional position. So it is necessary to note whether challenging cervical and scapular muscles to work in dynamic posture creates a positive impact on craniovertebral alignment and improvement in deep neck flexor endurance. So the study aimed at to compare the effect of Brugger's postural relief exercise along with craniocervical flexion exercise and craniocervical flexion exercise alone on the alignment and deep neck flexor endurance in patients with forward head posture. The objectives were first to compare these two interventions for 3 weeks on the alignment of cervical alignment using the craniovertebral angle in patients with forward head posture, and to compare the intervention effects after 3 weeks on the deep neck flexor endurance using a craniocervical flexion test in patients with forward head posture. It was an experimental study carried out on 56 participants with simple random sampling, and both the genders were included in this study, and age group with the age group of 18 to 30 years. The patients who can hold the Brugger's position for 10 seconds were included in the study. The written informed consent was obtained from the Institutional Ethical Committee, and the permission was also obtained from the Institutional Ethical Committee. Group A received craniocervical flexion exercises with pressure biofeedback, and Group B received postural relief exercises with scapula retracted against the resistance band with chin tucked in with the craniocervical flexion exercises. The frequency was thrice per week for 3 weeks, and the outcome was measured using craniovertebral angle using on protractor app, and the effect on endurance using the pressure performance index using the pressure biofeedback system. Coming to data analysis and results, so the normality of the data was tested previously with the Shapiro-Wilk test, and that's why the paired t-test was used for intragroup comparison and unpaired t-test was used for the intergroup comparison. The individually craniocervical flexion exercise and the posterior relief exercise along with CCFE showed a significant improvement intragroup, and when compared intergroup, both the craniovertebral angle and endurance showed significant improvement with a p-value of less than 0.05 for both craniovertebral angle and endurance in calculated by using pressure performance index. So coming to discussion, strengthening the scapular stabilizers improve the scapula position and increase the craniovertebral angle that results from the reciprocal inhibition resulting when the antagonistic scapular stabilizers are in maximum voluntary contraction that relaxes the ergonist deep cervical flexors. By retracting the shoulder and maintaining isometric contraction of neck in chin tuck position, the deep cervical flexor muscles also get targeted and strengthened. These muscles are also significantly, the endurance is significantly improved because chin tuck along with scapular retraction in an upright posture requires the scapula to work dynamically to maintain the corrected position that helps reverse the forward head posture. The Brugger's position, which is nothing but patient sitting and flexing his elbow at 90 degrees with arms in external rotation position, he will just activate the shoulder retraction and will extend the elbow along with extension and external rotation, and he will maintain the chin in tucked position. So this position was given to the patients. So it concludes that Brugger's posture relief exercise along with craniocervical flexion exercise helps in improving forward head posture in terms of craniovertebral angle and deep neck flexor endurance as compared to craniocervical flexion exercises alone. And future scope, we wish to follow up the study considering the carryover effect of the corrected forward head posture. These are some of the references. Thank you.
Thank you. The paper is open for discussion. Any questions, please?
Can I give one suggestion? Yes, actually,
Yes.
you know, it's a very nice presentation, nice work, but no photograph, no images. That should be included. It will make everybody clear the what is your work and what type of work you are doing.
Yes, sir.
Okay.
Thank you, sir. We'll do that.
Thank you, sir. Any questions from the audience? Any more questions? Judges, your questions, please.
Yeah. Nice attempt.
Thank you, sir.
I just want to know the data of your study. I'm just asking you. Do we have a proof that craniocervical flexion exercises has got an impact on the outcomes that you're taking?
Craniovertebral angle, yes, sir. And deep cervical flexor endurance also, because those muscles are targeting deep cervical flexors, because the exercise that we opt for the global muscles for strengthening of cervical flexors, extensors and other muscles, we should first work on the deep cervical flexors, because there has to be some interaction between the superficial cervical muscles and deep cervical muscles whenever we are giving actual strengthening exercises to the patients. But then we should not directly start with strengthening exercises in all before targeting the deep cervical flexors exercises. So, that's why the deep cervical flexors were targeted.
Your ultimate aim is to have an increase in your cervical, your craniocervical angle. That is from forward neck posture to getting back to your normal lordosis.
Yes, sir.
By activating the deep cervical flexors, are we trying to create flexion of a neck or extension of the neck complexes?
So, generally with weakness of deep cervical flexors, the patient generally tries to extend the head rather than tucking the chin in. So, we want a proper interaction between those muscles. It's not only one muscle that we want to recruit, but it's a proper interaction between the superficial flexors as well as extensors.
Getting onto your theory of interdependency, when probably I'm trying to train my deep neck flexors, and it tries to pull my neck flexors in front, tries to get my cervical into flattening of a neck. Here you're trying to create training for your deep neck flexors, and you're evaluating for a cervical craniocervical angle that takes you into extension. And I find it little contradicting for the understanding of my ideology of biomechanics. One. Number two, you have, it is already being proved that probably training my cervical neck flexors is having an impact on some XYZ component, and training with your other training program of your various exercises is helping you for it. It's 1 plus 1 definitely comes down to score of 2. Now, in what way your added intervention creates an impact, and how does it stand identical that your added program caused you a change only in this parameter? That's what we're looking for. Globally, generally, 1 is giving me a change. Adding 1 plus 1 will definitely give me a change against as existing 1. If that 1 plus 1 is making a different change, what concept or what context or what mechanics or what pathomechanics is being identified or reversed pertaining to your added impact, that is what is to be looked on for a better studies.
Yes, sir.
So can you explain it here?
Yes, sir. So the ultimate aim of giving craniocervical flexion exercises, or we give those exercises specifically in supine position with scapula stabilized by the plinth, wherein the scapular stabilizers as such are need not to be activated in supine position, but this position added to that targeted more of a scapular stabilizers with chin tuck position. So that was the ideal idea behind giving an additional dynamic challenge or a dynamic position challenge for the scapular muscles to work along with the cervical deep neck flexor. So that was the idea, that traditionally we are using the cervical deep neck flexor endurance exercises in supine position where the scapula is stabilized by the external stabilizer. But in this position, the new Brugger's postural position, we are targeting the scapula in dynamic posture. So specifically, if you consider the 18 to 25 years of age group, this population is not symptomatic as such with forwarded postures. So just giving ergonomics will not work. So they have to give some challenge and target that, okay, this is your wrong posture. So how can you correct it? So these are the exercises which can help. So that was the aim behind giving scapular dynamic position for that.
Right. My third concern, which usually exists in all researchers, is this. We have this basic protocol of 3 times a week for 3 weeks or 4 weeks. A protocol that is running for around 10-15 minutes to the maximum, activating a muscle for around 10 to 15 contractions for a couple of seconds. When you are activating a muscle for a couple of seconds, in a day of 24 hours or in wherein we are using your muscles against your normality of mechanics for around 18 hours a day, and we are training into a proper recruitment for a couple of 15 minutes in a day, and that even for 3 times a week for 3 sessions, coming up to around 9 to 12 sessions maximum. I still couldn't understand the concepts, how that 1 hour or 1.5 hour of total timing of training can outwit your next 18 hours of day or 17 hours of day into 12 weeks, so into your 3 weeks, that's 21 days. How does that 1.5 or 2 hour of training can outwit the abnormal mechanics a human body interacts with every day for a period of 3 weeks? And we always show it shows exorbitant results at the end of 3 weeks.
Yes, sir.
I still couldn't understand that most of the researchers, probably if somebody else could prove me also, it will be good enough.
So you're absolutely right. This was a challenge for us because this is a asymptomatic populations. They don't come to you for treatment. We are just putting them into the preventive category. So we are not treating them as a patient. Rather, we are just preventing the consequences of being in a wrong posture. So that's why the frequency was kept minimum, so that at least they will do some sort of exercises in that particular frequency. Because it's a big challenge to convince them for
understand the preventive concept. The only thing is, your body appreciates your mechanical proprioception depending upon the number of hours it is maintaining in towards mechanics.
Yes.
And for 17 hours a day, my body maintains that abnormal posture, and we are training the individual for 15 minutes or 20 minutes, half an hour in a day. I mean, I anticipate that 30 minutes of that particular training will outweigh your 17 hours of your abnormal abnormal mechanics, and usually show results.
Yes.
Which I probably don't understand the concept, but many of the researchers, not only yours, please, and
No,
many
sir,
researchers.
Yes, sir, that's true. But I think there should be something is better than nothing. So I think even if they do exercises for such a short time, but they are doing it, so that should be a positive outcome of my study. Thank you, sir.
Thank you.
Thank you,
Thank you.
ma'am.
Thank you so much.
Thank you.
Now I call upon KCON 07.
Good morning, everyone. Good morning, respected judges. I am presenting the study titled The Effect of Balance Training on Dynamic Balance in Young Adults with Pronated Feet aged 18 to 25 years using Nintendo Wii Fit. Starting with the introduction, as we all know, the dynamic balance is the ability of the body to maintain its center of gravity within the base of support while changing the direction or while movement. It relies upon central and peripheral nervous systems. The peripheral nervous system contributors are somatosensory system, visual system, and vestibular systems. So the inputs from all these systems, if it is integrated with CNS, and the proper musculoskeletal response will be decided by the body. Coming to foot biomechanics, it plays a key role when the body should be maintained the balance in static and dynamic position, as it adapts to the ground surface, absorbs the shock, and acts as a lever for propulsion. Previous research shows that individuals with pronated feet have poor dynamic balance, as there is poor ankle stability, reduced medial and lateral arches, and increased demand on neuromuscular system. There are different methods for balance assessment like force plate, star excursion balance test. SCBT is a test which assesses dynamic balance in multi-directions. Different balance training tools are balance board, wobble board, vestibular ball, balance master system, but these are less accessible and costly. From past few years, video games and virtual reality is gaining popularity as a training tool in balance training. As it is so the Wii Fit balance board, which is invented in Nintendo Japan, is one of the novel approach, which is interactive and engaging. It provides real-time feedback, so the motivation and compliance is higher towards the treatment. As there is a limited research specifically targeting individuals with flat feet using this method, thus the need of the study. Coming to aims and objectives, to find the effect of balance training with help of Nintendo Wii Fit on individuals with pronated feet, to check the feasibility of Wii Fit as a balance training tool in individuals in this population, and to improve balance in individuals with flat feet. This was a quasi experimental study, was taken place into the community. Sample size is 35. Age group 18 to 24, both the genders were included. Individuals with pronated feet were included. Exclusion criteria was recent injuries, ankle injuries, recent lower limb surgeries, and individuals undertaking any physical therapy for lower limb. Coming to procedure, the population was screened by using foot posture index, and the individuals were detected with pronated feet were included. Dynamic balance test was assessed using star excursion balance test pre-intervention. Then they were introduced to tiltable game using Nintendo Wii Fit. They were trained for thrice per week for 4-week protocol. And last step was the dynamic balance was reassessed after the 4 weeks, and pre-post analysis was performed. These are the results. As we can see, there are two graphs for right leg as well as the left leg. There was considerable change found in SCBT measurements in all the directions. Discussing the result, as we could see, there is a high significant SCBT improvements, greatest in anterolateral, lateral and posterolateral directions. The game was multi-directional weight shifting game, so it enhanced the postural control, which is a key prerequisite for the dynamic balance. Due to preferable ankle strategies, the improvement in specific direction was found out. As it was a multi-directional games, there were targets and the object. So the patient could choose which ankle strategy to choose, and that's why the specific direction improvements were observed. One more finding was observed. Pre-intervention, multiple attempts were required for the SCBT reach test, whereas after the intervention, controlled and steady movement was observed. And this intervention may improve balance in other populations with flat feet like athletes, geriatric population, pathological conditions like OA knees and ligament injuries. And coming to the conclusion, the study proved that Y-Fit can be used to improve dynamic balance in individuals with pronated feet. Also, it is a feasible balance training tool in this flat feet population. These are the references. Thank you.
Thank you so much. The paper is open for the discussion. Any questions from the audience? Sir, any questions? Any questions, please? Judges, your questions, please.
Good attempt at the study. I would just like to give few advices.
Yes.
In the introduction slide, you mentioned about different balance assessment tools which are being costlier. But to my personal experience, your BFIT device is much more costlier than them. So when you speak, you need to be a little careful about what words you choose. The other thing is in results and analysis, you should always try to look for statistical significance versus your clinical significance.
Okay.
Because I feel in the subjects or the participants of your study were all asymptomatic ones.
Yes, ma'am.
The only significant finding was the pronated fit.
Yes.
Right?
Yes.
So you should give importance to whether
Clinically.
the results were clinically significant.
Okay, ma'am. Yes, I'll take that into mind. Thank you.
Thank you so much.
Thank you.
Now I call upon KCON F08.
Good morning, judges. The title of my study is Effect of Exercise Intervention on Pain, Disability, Job Satisfaction on Mechanical Neck Pain in Desk Job Employees Working from Home, a randomized control trial. Work from home surfaced in early 2000 and which was increased during the COVID period. This brings its own challenges and profits. Work from home avoids the communication, provides flexibility in working schedules and achieving a better work-life balance. But it also challenges the dedicated workplace, lack of proper equipment and multiple members of the family working from the home simultaneously sometimes. Portable gadgets like laptops allow people to assume any posture they want, ranging from sitting in a chair to lying in the bed. The neck pain affects 45% of today's working population. Many studies have been carried out for the prevalence of neck pain amongst them, but studies on job satisfaction, its disability, and exercise intervention for the same is the need of the hour. The aim of our study was to study the effect of exercise prevention on pain, disability, and job satisfaction on mechanical neck pain in desk job workers working from home. And our objectives were to assess the pain, disability, job satisfaction, and mechanical neck pain in the desk job workers working from home, and to compare the effects with the control group. Our study design was single-blinded, active control parallel group trial where the assessor was blinded. Our inclusion criteria was age group of 20 to 55 years, employees working for more than 2 years from home, and minimum working hour of 5 hours per day, and they had complaints of neck pain from the 3 months. Our exclusion criteria was employees suffering from musculoskeletal related conditions such as rheumatoid arthritis or any connective tissue disorders, having cervical fracture or any impairment or surgery of the upper limb in the past 6 months, or any neurological signs, and if they have started working from office post a period of working from home. The procedure was, after the ethical committee clearance, we had a written consent from our participants, and then we took their baseline as well, their baseline outcome measures, and which were reassessed after 4 weeks of intervention. The group B was our control group, which received only a pamphlet which included ergonomic advices, and group A received intervention of ergonomic education as well as on exercises. The exercises included stretches and scapular muscle strengthening as well as chin tucks. The participants received 12 sessions, 3 sessions per week for 4 weeks. For our results, in the inter-group analysis, we found that there was significant difference between in pain, neck disability index, as well as job satisfaction. But in intergroup, which was shown here, our intervention group showed a higher amount of difference in the pain changes as compared to the control group. But the disability as well as the fear avoidance or work satisfaction was seen more in the ergonomic groups when compared to each other. This brings us to the point that both exercises as well as ergonomic advices are helpful for reduction of the neck pain. Educational program could have had an upper hand because it provides a doable situation or doable solution for the working from home participants. Our conclusion is supervised exercise intervention as well as a passive education program shows statistical and clinical relevance significant in elevation disability level, fear avoidance, and job satisfaction. However, a supervised exercise intervention shows a better result in elevating pain as compared to the control group. These are my references. Thank you.
Thank you so much. The paper is open for discussion. Any questions?
So far I understand that in the work from home group, there are the 3 groups you have, means 3 divisions. One group will get the exercise, another group will get the instructions, the ergonomic instruction, and the third group will get the exercise and the instruction.
No, sir. There were only 2 groups. One group, which was the control group, received only the ergonomic advices or the pamphlet in the form of a pamphlet, and one group, which was the intervention, which was combination of the exercise intervention as well as the ergonomic advice pamphlet.
Yes, that means there are 2 groups.
Yes, sir.
So you can divide into 3 groups also. Okay. So the comparative study will become more,
elaborative, and
yes,
it will give us
you can explain it more clearly then.
We'll try doing that.
Very
sir.
good.
Thank
Very
you so
nice.
much for the suggestion.
Thank you so much, sir, for your suggestion. Judges, your questions, please.
Of course, work appreciation is there.
Thank you, sir.
But on the basis of today's, because we have to find for the quality of your presentations. So just go back to your data presentations. Result data analysis, I couldn't pick up with this particular graph, what it is trying to tell me.
Okay, sir. This is an intergroup data which I have represented in this graph. The group A, which is the intervention denoted by the blue one, and the orange one is the control group. This is representing the pain. So
pain was taken using what outcome?
The pain was assessed using the Orebro musculoskeletal pain questionnaire. So Uh-huh.
Wasn't clear for me.
Right, sir.
Next.
The next one was disability, which was taken using neck disability index.
NDI index of between, the score tells me between 5.5 to 7.
Yes, sir.
How significant is this difference?
Sir, it is not significant statistic.
But you claim that it shows very good impact by giving both your structures to the patient.
So when we do an intragroup, which is within the group, both the control group as well as the intervention group showed statistically significant outcomes.
But NDA score of 5.5 and 7 make no clinical significance.
Yes, sir. That is true, sir.
But you claim that it is actually better. Next.
Fear avoidance was taken using fear avoidance belief questionnaire. It's a 16-item questionnaire, sir.
The 16-item questionnaire, the maximum score it's showing is 8.
Yes, sir.
And the score, the pre and post of the group B, the difference is hardly anything.
Yes, sir.
Still
Again,
you claimed that both of them are actually, that there's a difference by giving both the interventions together. But your post results show me the same. It's 7 and 7 by and large. So because like I wasn't clear, since you explained it to me again, I got it, I could pick it up.
yes,
So it might show me that it simply indicates that, this indicates whether you give a pamphlet or whether you give a pamphlet and the intervention, both look similar.
yes, sir. Which was a surprising finding for us also.
But this is what I interpreted after the explanations on the review of this graph against probably what you have claimed it in your presentation. Don't take me wrong.
No, sir. Probably I was lacking in the explanation part. I will improve on that, sir.
Because I didn't pick it up when you are flowing it fast.
Yes.
Thank you.
Thank you so much.
Thank you.
Now I call upon Kinesiocon F09.
Good morning, everyone. Good morning, respected judges. The code for my presentation is KF09. The title of my study is Awareness of Ergonomics in Chartered Accountants. So as we all have been learning since yesterday, ergonomics is a scientific discipline concerned with the understanding of interactions among human and other elements of a system. Here, by other elements of the system, we mean the job design, workstation design, the furniture around. It also includes the ease with which the person can use the digital appliances that he has to use during his work time. Proper ergonomic design helps to reduce musculoskeletal disorders and repetitive strain injuries. So chartered accountants need to work on laptops or computers for prolonged durations, and their work includes discussions, typing, clicking, and looking at the screen for long durations. So while doing this, they also assume various awkward postures because they do this on a regular basis and for long hours. That is why that was the need of my study, that we need to evaluate what is the level of education of our clients to help them rise above their problems and help them in preventing any further injuries to whatever extent is possible for us. The aim of the study was to find out the awareness of ergonomics in chartered accountants. Objective was to know whether they are aware of the ideal positioning of the body while working. To achieve this objective, we had formulated a closed-ended questionnaire containing 21 questions based on the review of literature. While formulating this questionnaire, after the formulation of this questionnaire, we had face validated it from 3 physiotherapists who were working in industrial setups, industrial therapy, and We also took inputs from one chartered accountant. 392 chartered accountants working in various areas across Pune city were included in this study. And, this questionnaire was pilot run over 30 participants, and then some of the confusing questions were modified, and then it was rolled out for the actual study. Inclusion criteria in this was subjects working as chartered accountants for at least 6 months, and exclusion was the subjects who knew about ergonomics after they were educated by a physiotherapist, after they consulted a physiotherapist for some musculoskeletal complaint, and then they were educated by a physiotherapist. These are my results. In table number 1, I have averaged the results for visual ergonomics. You can see then for upper limb ergonomics, lower limb ergonomics, spinal ergonomics, and ergonomics about the frequency of breaks that should be taken at regular intervals. And in the table number 2, I have highlighted some important questions and the results. For example, only 12% of the CAs were aware about the ideal distance between the eyes and the laptop screen. So you all can see there are various the results range from 11% to 89%. That is 11% is the awareness about inclination of the keyboard, and 89% is the awareness about whether the breaks should be taken at regular intervals or not. So coming to the discussion, in this study we found out that the percentage of people who were aware about the correct distance was very low. In a previous study, it has been found that individuals working on computers have computer vision syndrome, that is eye fatigue, burning of eyes, and it has also been found that using anti-glare filters and ergonomic positioning of the laptop accessories reduces ocular symptoms to a great extent. Also, resting the arms while working, and if we keep the level of armrest at a proper level, considering the person's stature and everything else, the stress on the upper back muscles is reduced to a great extent, and the posture also improves. In other professions which require working on laptops and computers, neck pain and lower back pain were majorly reported problems. It has been seen that longer seating hours lead to accumulation of metabolites, and it accelerates disc degeneration. Also, inadequate breaks while working are significantly correlated with pain and loss of productivity. So in previous studies, they have reported that software programs stimulated work breaks increase the productivity of individuals working on computers for long durations. Coming to the conclusion, from this study we can conclude that the percentage of awareness of ergonomics in chartered accountants was low, and there is need for education in them. Also, I would like to emphasize that clinical implication of this study is that new recruits can be trained about ergonomics, and also in today's era, ergonomics and computers have become a part of daily routine. So some knowledge about ergonomics and positioning of ergonomics should be included in the curricula of the school, because children also use use computers to a great extent nowadays. Also, one of the clinical implications is that ergonomics improves the efficiency and work productivity. So also the profit making and for improving the productivity of employees, it is important that we educate them about ergonomics. Thank you. These are my references.
Thank you so much. The paper is open for the discussion. Any questions?
That one thing I want to ask you, that you already developed a questionnaire, So did you perform the reliability of the questionnaire? Did you check the reliability of the questionnaire?
Sir, the reliability exactly was not checked. The face validity only was done. Yes, so due to restriction of time, we did not do that, but it should have been done, yes.
Because in future, when you develop a new questionnaire, the reliability should be checked.
Okay.
There's a statistical method already there through which you can check the reliability.
Okay.
That's all.
Thank you so much, sir. Judges, any questions? Okay. Thank you so much.
Thank you.
The last paper of the category, Kinesiocon F10. I request all the presenters to be in in the hall. We are going to distribute the certificates after this presentation.
Hello. Hello. Good morning, everyone. My code is KCON of F10. I'll be representing upon the effect of lumbar sustained natural epiphyseal glides on pain, gait parameters, and disability in patients with chronic low back pain. As we all know, we have been discussing this chronic low back pain is something which is a never-ending problem. It's still going on and in future going on. The treatment options we have are still a lot of there, but it is a holistic approach what we still require. Hence, the need of the study is we are finding out the solutions which are easier for the patient to be done at home, and also which shows an immediate effect when the patient comes with you with any pain, disability, or gait parameters. We see that in patients chronic low back pain, they normally have a protective mechanism when they walk, which shows that the decreased speed, acceleration in the lumbar muscle activity has been reduced, shorter step length and stride length. It shows that lumbar snag shows an immediate effect on reduction of pain and disability and change in the gait parameters by the concept of correcting the positional fault, which gets developed due to any injuries, which gets developed due to a prolonged chronic low back pain, positional faults, as well as improper posture. There's a paucity of literature still in chronic low back pain and gait parameters, and there is also a requirement of treatment options which will be useful for the patients to get a better results. Hence the need of the study. The aims and objectives to study the effect of lumbar snag and conventional therapy on pain, disability, and gait parameters in patients with chronic low back pain. The objective of the study was to study the effect of lumbar snag and conventional therapy. The second objective was to compare the effectiveness of snag and conventional therapy in patients with chronic low back pain. The methodology used here was an experimental study where a sample size of 30 random sampling was done. The inclusion criteria includes of male and female with age group of 25 to 50, where we commonly get to see this low back pain, specifically chronic low back pain, and also the patients who are having pain more than 3 months. The exclusion criteria are patients with any acute low back pain, any infectious disease, patients with hip and knee OA, lower limb fracture, any recent lumbar surgery and lower limb surgery was excluded. Pre and post assessment was done using pain on NPRS, disability on Oswestry Disability Index. Gait parameters was done by using a footprint method. The group was divided into 2 groups, each of 15 groups in one. In one, the experimental group, it was given lumbar snag plus conventional therapy, which include hot pack. TENS modality was given along with our basic conventional exercises. Group 2 was given conventional exercises alone. The results and data analysis says that there was within the group, the difference was significant in pain, step length, disability score, stride and cadence. The score from pain difference shows from 6.8 which went to 3.13 in group A, whereas in group B it was 7.6 to 4.53, whereas step length, stride length and cadence it improved a lot. Cadence it improved. Disability score from 35 to 33 in group A went to 18.4, whereas in group B it went from 38.33 to 23.8. The comparison was done within and between the groups. Within the group, it shows significant improvement in all the parameters, whereas between the groups, pain was significantly more improved in group A comparative to group B. The discussion says that when we give this when we give this treatment like lumbar snag and conventional therapy, shows that it shows a lot of neurophysiological changes that occurs at your spinal level, physiological changes which are nothing but descending the pain inhibitory systems and central pain processing system, which supports my finding of showing a significant improvement. It also says thus combining the joint glide and the physiological joint movement together overcomes your biomechanical and neurophysiological joint problems, which cause more effect in your outcomes. Conventional therapy, when combined with your mobilization therapy, shows an effect in reduction of pain. When you use your electrotherapy, it works on the pain gate mechanism. Static exercises helps to increase the intra-abdominal pressure, which in returns improve your postural stability, as well as it enhances your spinal and pelvic stability, reduces the pain level, strengthens the muscle, and improve the overall stability. A study done by Hegnan et al. In 2015 says that positional fall gets corrected, patient pain reduces, which in helps to make the trunk movements free. Patient gets a self-confident to move, hence a better improvement in the overall protocol, and which plays an important role in your pain reduction, gait parameters, and your disability score. The conclusion says that hence in the study, the comparison was done between the SNAC and the conventional therapy. We found that both were equally significant in improving the parameters, but a conclusion says that additional of SNAC therapy for your conventional therapy shows a better outcome measures when you give conventional alone. The limitations of my study was gender difference was not done. Second, the range of motion in the dominant side leg was not done. Also, to check the gait parameters, advanced gait assessment things was not available, hence it was not done. Thank you. These are my references.
Thank you so much. The paper is open for discussion. Any questions from the audience? Any question? Judges, your questions, please.
Right. So you would like to conclude that adding up snacks with conventional therapy helps you to get your parameters better improved on
Better
pain disabilities.
impact. Yes.
Slide number 5. Blow it up. Slide number 5.
Up.
Full slides, full screen. So appreciating that from your disability score, from 38 it has become 23.8 and 35 becomes 18.5 in the group A and group B.
Yes.
The difference in group B is how much? 38 become 23.
It's approx 14.
14 plus 14. And your disability of a group A from 35.3 it becomes 18.4. The difference is?
More than 15, like
16.
16.
The score of, in a disability score, that gives you a maximum score of 46.
Right.
A score difference of 1, does it make a change?
Statistically, it doesn't make a get, but significantly when we were scoring about things, there was significant improvement, and also the output from the patient gives us that feedback ki yes, it was significantly improved because they could immediately see the effect.
When you claim that my pain is reducing, my structure, my other problems are actually getting down, my disability score is not showing me a change.
Okay.
So with my step length has improved from 16.8 to 17.63. It has increased by 1 inch. Wherein my 17.03 to 17.88, it is increased by 0.8 inch.
Right.
A change of 1 inch of my step length, does it make a difference for an ambulation of gait?
Right.
Let's be clinical. I am walking with a 1 inch longer step.
Right.
How much of difference does it going to make? Same goes in going down for your stride length. From group A, from 34 it has come to 35, and from 34 it came to 35 again. Even the stride length. Stride length showed me a change of 1 inch. I am not a CP child where every inch makes a change. I am an individual who has been walking, who I am walking and will be walking for next tomorrow also.
Right.
A change in 1 inch, if I am taking probably 12 steps, I will be having 1 foot increase in my length.
Right.
Now, is it going to make a bigger change in the gait?
To be statistically, yes, it won't make a bigger change, but then if we take this as a whole and if we keep on giving...
Your claim at the end of the day, by adding up a snacks, it gives me a huge lot of change in disabilities. Then the pain reduces, disability decreases, your gait improves. Now, Doesn't gait improve with a 1 inch change?
It's
is what
not.
is-
It's not only with the 1 inch chain gate. Depends on various other
Are
factors
we
as
not?
well.
Are we not then probably trying to hyper escalate that something is being added and something is giving you better results?
Okay.
When convergence therapy is working you equally better, and you are giving that adding up a snacks gives me 1 score change in disability, adding up a snacks gives me a change of 1 inch of change in my step length, straight length. Now, why should I go in for taking an effort of putting out the individual into a snacks of lumbar extremity, putting him into a strain, putting a physical therapist into a strain, pushing off my snacks, getting couple of extra movements being done, tiring you and tiring the patient for 1 inch of change in my gait after a couple of weeks of training programs?
Just a thing about this, why we choose about the snack is like because as we all know, we always have a fear of avoidance. Like we in back pain we normally have a fear of doing any movement, but when snack, when you give that, you actually ask the patient to do the fearful movement and you give the snack at that time, and then post the treatment you do see an immediate effects which gets a patient confidence, which is my future scope for the same study, where we gonna take the questionnaire about your psychological aspect, get the questionnaire about your fear avoidance, about the movements. That's the reason this study is just part which we're gonna further carry about the psychological, which I am in process adding in that yoga part as well.
Was this a one-time study?
No, this is a follow-up study.
When you're giving a follow-up study for a
Right.
couple of sessions for a couple of weeks,
Right.
a disability score changing for 1,
Right.
and a change of gait changing for 1 inches.
We
Look up. You're putting on efforts of work for weeks together,
Right.
and what do you get at the end of the
It's
day is
just-
1 as a disability score change, 1 as a stride length change or a
Right.
step length change. Statistically, you say that snacks adding up gives you better results, but clinically it is looking to the fact
Clinically.
of life of a patient.
See, your main intention was to see whether snacks work.
Yes. Right. Okay. Right. Right, ma'am. I'll take into this. Okay, ma'am. Okay, ma'am. I'll take this into consideration for the next time. Thank you.
Thank you, everyone. Now I request the judges to please come on the dais to distribute the certificate. We'll give, sir. Please go. Yes, ma'am, you also. Please. Darshan. Dr. Shreya Deshak. Darshan, यहाँ पे खड़े. Dr. Mayuri Kataukar. Dr. Namrata. Dr. Namrata. Dr. Tejaswini Varute. Dr. Sharayu. Dr. Sharayu. Dr. Sharayu. Dr. Pallavi Chopre. Dr. Apurva. Dr. Apurva. Dr. Fareen Patel. Dr. Fareen Patel, Dr. Priyamvada Hinge, Dr. Priyamvada, Dr. Anuja, thank you so much. Thank you, sir. Thank you, ma'am. Thank you all the presenters for presenting the scientific work at Kinesiocon, 6th Kinesiocon, and especially abiding by the theme ergonomics. We are happy to see most of the papers coming from ergonomics theme. Thank you so much. Please join us for the tea. Thank you. Thank you.